Good morning. Welcome to our online event, How Neuropalliative Care Can Improve Quality of Life for People with Parkinson's. Today's program is brought to you by Parkinson's Community Los Angeles, and we are so fortunate to have with us Emily Downing-Mahli and Dr. Jessica Besbris. I'm Angela Neff. I serve on the PCLA board. For those who don't know us, we are a nonprofit that supports families living with Parkinson's through free education programs like this one, online and in-person support groups, social events, and so much more. Today's conversation is brought to you by our generous sponsors, Abbott, Acadia, and Boston Scientific, and by important donations from people just like you and me in the Parkinson's community. If you appreciate our programs, please consider making a donation at pcla.org. Your donation is 100% tax deductible, so thank you so much in advance. We rely on your generosity to help us continue this important work. Please join me in welcoming Emily Downing-Mahli, an advanced certified hospice and palliative care Adult-Gerontology primary care nurse practitioner, that's quite the title, who completed her Bachelor of Science in Nursing at the University of Massachusetts, Boston in 2002, and Master of Science in Nursing at the University of California, Los Angeles, 2016. Her career includes managing high-risk patients during post-acute hospitalization, a successful pilot as a post-discharge visit nurse practitioner to reduce hospital readmissions, and a broad range of experience in older adult care, from wellness to end-of-life care in various settings. Emily helped to run Cedars-Sinai's geriatric fracture program, where inpatient care is optimized for older adults who sustain fractures and initiate secondary fracture and fall prevention. In her current role at Cedars-Sinai, Emily provides outpatient neuropalliative care to persons living with serious neurological disorders. And Dr. Jessica Besbris. Dr. Jessica Besbris completed her neurology residency at UCLA in 2015 and her palliative care fellowship at the West Los Angeles VA in 2016. She is board certified in both neurology and hospice and palliative medicine. She is an assistant professor of neurology and medicine at Cedars-Sinai Hospital in Los Angeles, where she provides inpatient and outpatient palliative care consultation to persons living with serious neurological disorders, and serves as the Director of Neuropalliative Care. Dr. Besbris is passionate about education at the intersection of neurology and palliative medicine, and provides formal neuropalliative instruction to palliative care fellows and neurology residents. She is the past founding co-chair of the International Neuropalliative Care Society's Education Committee, the past founding chair of the American Academy of Neurology's Palliative Care Section, and the past founding chair of the American Academy of Hospice and Palliative Medicine's Neuropalliative Special Interest Group. My goodness, we have two amazing, powerful women here. Welcome, Emily and Dr. Besbris.
Thank you. Thanks for having us here today. So I'm a clinician as well as a daughter-in-law to a beloved family member that lived with atypical Parkinsonism. So I'm here to discuss what we know about Parkinson's disease and how palliative care is so beneficial. I'd like to explore aspects of palliative care, what it is, how it helps people to live their best life, support caregivers, and help plan for the future. We know that Parkinson's disease is a lifelong disease, and for some people, Parkinson's disease can bring them to the end of life sooner. It is second to Alzheimer's dementia as the most common neurodegenerative illness. According to the World Health Organization, the prevalence of Parkinson's disease worldwide has doubled in the past 25 years. We know that the burden of symptoms in advanced Parkinson's is equivalent to those with advanced cancer and ALS. We also know that every individual's experience with Parkinson's disease is different. There's a high degree of variability from person to person, as well as possible fluctuations in disease from day to day. What we know is Parkinson's disease treatment is geared toward managing symptoms. There is a considerable impact, both psychologically and socially. Caregiver strain rises as disease progresses and symptoms change. And people with advanced Parkinson's disease are at risk for hospitalization. And we know that hospitals can be highly dysregulating, especially for those with memory impairment. You may go into the hospital with one problem, but leave with many more, including increased disability and need for more care. So what is palliative care? Palliative care is really two things. It is an area of medicine and a broader approach to care for people living with serious illness. The term palliative comes from the Latin word to cloak, which I love because we really are an extra layer of support. The goal is to reduce suffering by managing intense symptoms, promote psychosocial and spiritual well-being, help plan and prepare for the future when living with serious disease, and reduce caregiver stress. So what is palliative care? It's person-centered care. So what does person-centered care really mean? The World Health Organization defines person-centered care as an approach to engage and empower people to take charge of their own healthcare instead of being passive recipients of healthcare services. So that means interactions with providers are no longer transactional. You're not going in with symptoms to get a diagnosis or get medications. It is meant to be whole person care, where we get to know the people and family, whoever they are, and understand their lived experience. Hope is that the healthcare team walks this journey with you to understand what your values are and what is important. So essentially, our agenda is your agenda. So from the beginning, the purpose of palliative care was to improve the quality of life of all people and families facing serious illness, to move beyond the direct management of their disease, to address what Dame Cicely Saunders defined as the principles of total pain of serious illness. So total pain is not just physical, but psychological, social, and spiritual. Dame Cicely Saunders is the founder of the modern palliative care movement. She was trained as a nurse, a social worker, and a physician, really a palliative care team unto herself, who recognized the inadequate care of those dying in hospitals, alone and in pain. She created the movement with St. Christopher's Hospice in England in 1967 to provide the compassionate care for cancer patients at end of life. Her influence has helped change standard models of care from disease-directed to a palliative approach, which is people-directed. So why palliative care? We know the diagnosis of Parkinson's disease is traumatic and often given without acknowledging the impact to quality of life, such as potential loss of physical and mental capabilities, loss of independence and ability to perform day-to-day activities, as well as undertreated non-motor symptoms such as pain and depression. In palliative care, we want to address challenges that are interfering with what matters most. So we're seeing a growing body of literature that supports the benefit of palliative care in Parkinson's disease. This one randomized clinical trial demonstrates that outpatient palliative care improves patient quality of life as well as caregiver burden. So why palliative care in Parkinson's disease? Because we want to help people live better now. Palliative care carves out designated time outside of a regular clinical visit for discussion about feelings, about the uncertainty of living with Parkinson's disease, for grief and processing loss, setting goals for medical care, what is acceptable, and what are your non-negotiables.
It can happen in seconds.
And to help align that care by improving communication between the patient, their loved ones, and their healthcare team. So, myth or truth, patients must stop seeing other providers if they are seeing palliative care. That is absolutely a myth. It's just another specialty. Insurance covers palliative care just like cardiology. So I would also implore you to discuss with your own doctor, movement specialist, or primary care physician about how they can incorporate palliative principles into current care. Take interest in what your provider's thoughts are on palliative care. What do they know? So who does palliative care? Initially, primary care physicians or neurologists, movement specialists can provide primary or general palliative care, which is the palliative care from non-palliative care specialists, as people live for decades with Parkinson's disease. With additional education, providers can integrate the approach, and you can advocate for that care at any point in chronic illness. Palliative care specialist role, usually board-certified providers with education and training in the medical field of palliative and hospice care. I am board-certified in palliative care as a nurse practitioner, along with Dr. Besbris and Dr. Hawkins, who also completed fellowship training in palliative care as neurologists. Neuropalliative care is an approach to care of those living with neurological disease, to go beyond only managing symptoms, to improve coping, identify support, plan for the future. It's multidisciplinary from different specialties, medical and non-medical, to address those sources of challenge. And I want you to Google at the end, and I know I'm going to share my slides with you, but I want you to check out the International Neuropalliative Care Society, INPCS. Its specific goal is to promote neuropalliative care, interdisciplinary, international, person-centered standard of care to include people that live with Parkinson's disease and care partners have an equal seat at the table as other members, physicians, NPs, PAs, social workers, chaplains, nurses, bereavement counselors, researchers, and community advocates. So when should palliative care specialists be considered? So the old standard of care was to have palliative care offered at the brink of death, while the new standard should begin at the time of diagnosis for any serious illness. This can be done by the non-palliative care certified or a palliative care specialist. So the old way of thinking is that palliative care started when treatment choices directed at disease ran out or were causing harm. This meant that there was only a short period of time when palliative care could be provided before hospice was needed. This has led to a lot of fears about palliative care. That is the same as hospice. That when palliative care is involved, there is no hope. That palliative care is equivalent to the end of life. Because of the stigma, teams have changed the name, like Cedars-Sinai has, to supportive care medicine, but it is still palliative care. So when do we start? More and more, the field has shown that people benefit from palliative care involvement as early as diagnosis. And this leads to people not only living better, but in some cases of people who received early palliative care and advanced cancer lived longer. So there is no phase for palliative care. This is beneficial for any chronic serious illness. We need to educate and advocate that whole person care is a routine care. So this graph points to how palliative care needs can start at the time of diagnosis. It is an important time to understand goals and values, what is important now, so that we can really put the diagnosis of Parkinson's on the back burner to figure out what symptoms can we manage aggressively now so we can get you back to your life. So potential triggers for palliative care discussions include frequent hospitalizations, serious coexisting medical conditions, major functional decline, falls, and frequent infections. So what people see and what they don't see. Symptom burden goes beyond tremor and is similar to other conditions traditionally associated with the palliative approach. We know almost a third of patients report that their non-motor symptoms are at least as debilitating as their motor symptoms. And symptom burden is equivalent to those with advanced cancer, but unmet under the current models of care. So Parkinson's disease is not just a movement disorder, and non-recognition is the biggest reason for non-treatment. Research shows that using checklists to review symptoms can improve outcomes. So this can be a wake-up call for providers to not miss opportunities. So it's important to address existential or moral and psychological suffering of neurological disease, as Parkinson's disease can be experienced as intrinsic to self versus something like cancer that is external and something to beat. This may lead to difficult emotions such as loneliness and guilt, fears about future, as well as loss of identity and independence, and also grappling with the changes in appearances and changes in relationships. So we want to improve quality of life for care partners. We know it is already higher, this caregiver burden, than those caring for patients with Alzheimer's disease, especially care partners caring for patients with psychiatric symptoms, falls, and increased disability. Caregivers can have their own physical and psychological suffering, loss of independence, as well as feelings of being alone, leading to caregiver burnout. We are really good at preventing burnout versus reversing. So the caregiver's experiences, their resulting needs and support planning need to be regularly assessed at each visit. So what is the plan? And we want to talk about this in a non-crisis period. Dr. Zaldi Tan from Cedars Memory and Aging Program emphasizes the importance to talk to caregivers about backup plans, address the what ifs. We know that sometimes caregivers may be young and they may not have thought about their own death or being seriously ill, so this may be a different concept to discuss, but the earlier it's done, the easier for the loved one to process. Other thoughts may be logistics, providing care for a loved one that can no longer provide alone. So I always like to introduce a little Boston into presentations. This is the Lenny Zakim Bridge in Boston. And so what aspects of advanced care planning are most important for patients with Parkinson's disease? So I like to say the advanced care planning is the bridge to what you want, to what you get. So what to expect? Parkinson's disease is very difficult to stage, but we can do a general roadmap based on an individual's clinical state and trajectory. We can't perfectly predict the rate of progression, but we can use our knowledge of typical Parkinson's progression and provide a roadmap as to what is expected, personal to you, including sentinel events or signposts that are markers of disease progression or impending decision-making. We often do best case, worst case scenarios, and most likely. And we also want to explore what you know about Parkinson's disease. How much do you want to know? Maybe people want information in writing and come back with questions. The goal is to provide information while also checking in on how this information is landing with you and really support the process. So we know that people with serious illness often do not want to be a burden to their loved ones, and they want to avoid inappropriate prolongation of the dying process. While care partners, they want to be included in decisions and have their loved ones' wishes honored. Why advanced care planning? Because we know the vast majority of people say they want to die at home, yet the vast majority die in hospitals or nursing facilities. Approximately 2/3 of all people living with Parkinson's disease are hospitalized in their last 6 months. Of those hospitalized, 1/4 will die in the hospital, with low hospice referral rates. People with Parkinson's and families are rarely prepared due to inadequate advanced care planning, poor prognosis awareness, and poorly coordinated care. We can prevent inappropriate end-of-life care. So we want to empower patient and care partner communication. As things change, we're talking about it. Some people develop memory impairment, leading to poor decisions and care preferences. We want to meet people early to know their wishes. And we can also suggest questions or topics. Would it be helpful to talk about the future? Informal caregivers are often overlooked as key players in providing optimal care for people with Parkinson's disease. Therefore, we need to identify and involve the care partners. Durable power of attorney for healthcare. Who are your people? Ask, who do I trust speaking for me if I was unable to make medical decisions? Not financial, but medical. This is at any stage we should be thinking about this. And you want to let them know. We want to empower people to make important life decisions based on their values and likely course of illness, and complete the Advanced Healthcare Directive. So I posted a few examples, the 5 wishes. We also have Cedars-Sinai has an Advanced Healthcare Directive, a really robust, there's instructions and steps. These are legal documents that communicate your wishes for medical care if you're unable to. They're really principles to guide a future crisis. This also includes identifying your power of attorney. You know, and it's interesting, we notice a majority of these directives or living wills are done from lawyers at a cost. And these can be completed free or with minimal cost, even just to have them notarized. Healthcare should really have, these directives should really have medical input by your provider. I did just post this bright pink form, if hoping everybody's kind of familiar with the physician's order for life-sustaining treatment, or a POLST. This is an actionable, this is a form for a now crisis. It's actionable for an emergency situation. Do not attempt resuscitation is a very small piece, and a well thought out healthcare directive can help guide completion of a POLST. So what is hospice? It's one small piece of a bigger whole. Hospice is palliative care by a trained and interdisciplinary team when life expectancy is determined to be 6 months or less, where we continue to aggressively symptom manage and prioritize quality of life, whatever that means to the individual. So the Medicare hospice benefit is an entitlement, just like your prescription drug plan. If it applies, it mandates that an agency contain hospice and palliative care trained professionals. They should provide home equipment, hospital beds, wheelchairs, medications, respite care, also continuous care. It should have access for a 24/7 phone number. And if needs are too great, you find out if these agencies are contracted with some inpatient beds, if comfort needs can't be met in the place that they're at. They usually send nurses weekly, home health aides, a social worker. And when patients pass, care partners have 13 months of bereavement support. Why 13 months? Because we know that an anniversary can be difficult. So where do we go for hospice? Hospice will go wherever you are. So it's a private residence, an assisted living facility, boarding care, a skilled nursing facility or a nursing home, and in some cases, the hospital. I'd like to stress that before a referral to hospice, although certain therapies stop, some agencies actually will continue to pay for a few more sessions. You will always need to provide caregiving 24/7, and it's really important to interview these agencies. What is their experience with Parkinson's disease? You know, is the movement specialist or the primary care physician able to give a warm handoff or report to the admitting physician? And who is the attending? You know, it could be the Neuropalliative Care Specialist or your primary care physician. Do they have an associated inpatient unit if comfort needs cannot be met at home? We know that hospice budgets are very limited and really focus on comfort. So it's an important time to start deprescribing, removing aspirin or vitamins or cholesterol medications that won't necessarily provide benefit. And talk to your movement specialist, because we want to get maybe 90-day supplies of medications before admitted to hospice, or get that Botox for drooling or contractures, and then consider whether to pay privately in 3 months. So every individual is different, but dopaminergic medications should be continued. And if there are complications related to these medications, they need to be weaned slowly. So it's very important that all providers caring for individuals with Parkinson's disease understand the medications that have to be removed or should be removed that block dopamine. And we know that Haldol is a dopamine agonist or antagonist, and that needs to be removed from the medication kit and handed back to the hospice. We also know there are lots of other medications, hopefully your providers have educated you, such as Compazine, Phenergan, these are no-no medications, Reglan, a lot of over-the-counter sleep aids, Benadryl, and a lot of antipsychotics. So it's really important to have conversations with the providers about what your medication list looks like at all times. So we know hospice can provide education and counseling, tools and resources, support network, as well as bereavement support on hospice. When we better support our care partners, it improves patient quality of life. So a takeaway is, as we work towards advancing treatments and finding cures of disease, palliative care helps to improve the quality of life and reduce suffering now. So we want to educate patients and clinicians, encourage patients and care partners to advocate for their own care. We need to raise person-centered care as the expected standard of care. I will share my slides, but I was just throwing some of the specialty palliative care teams in our area. We have some in San Francisco, and also a mention of the International Neuropalliative Care Society. You can certainly, if you're a palliative care specialist and part of your team, you can certainly get a referral mentioned. So in closing, I just want to mention Dame Cicely Saunders' quote, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." Thank you for your time. Now we have questions.
Will Dr. Besbris also be doing some presentation?
I am here to support and answer questions, but this is
okay. Sorry, I thought you were both doing a presentation. That was amazing, and certainly opened up a lot of questions to me. I'll just start with, I kept thinking, well, what does it look like? Well, what are you going to do with, let's say I'm your patient and you come into my home. What will you do? Let's say I just got out of the hospital and I'm not in final stages of life. I have a long ways to go, but I'm just fragile. What exactly would you do?
So that's a great question. So when you say come to your house, I mean, we certainly have home health, we have PT/OT, we have community-based palliative care that often goes to people's homes. You might follow up. I mean, we want to make sure that you have post-hospital follow-up with your primary care physician and your movement specialist. We want to make sure whatever is changed from before the hospital, in the hospital, that it's actually happened post-hospital. We're going to see how you're doing at home, make sure it's safe. I mean, it's just it's that kind of multidisciplinary approach that we need to make sure that you're doing well post-hospitalization and that you continue to plug back into the system. I don't know if you were saying specifically about palliative care or outpatient. Did that answer your question, Angela? Sorry, palliative care would just
a little vague. So you don't do do you take vital signs? Do you do actual hands-on work with people? Do you do any kind of therapeutic questioning?
So we do, yeah. So we are a field of medicine. You might follow up with us. We don't follow you at home necessarily, but we can refer you to an agency that might have community-based palliative care as an option. The drawbacks is that insurance doesn't cover in-home palliative care. So we're just like any other specialty. You would come in, we would, do a physical evaluation. We would talk about your most pressing symptoms. We would evaluate the benefits of treating symptoms and all the other areas, but we're just like another medical provider, right? Just like cardiology, just like.
Got it. I thought it was more of a like that you would go into people if they were in a assisted living, you would go there or whatever, but no,
So that's hospice. Hospice can also be provided wherever you are.
So hospice is different than palliative care.
So hospice is palliative care, it is, but palliative care is larger. It is an approach to care that should be started at the beginning of any chronic serious illness.
Got it.
So it's approach of whole person care. I mean, I know it sounds crazy that we have to have a whole separate field of medicine, but the reality is that we don't provide this person-centered care in certain different specialties. I mean, hopefully in older adult care, geriatricians might practice this philosophy of care, but we know that neurologists do not get a lot of training in this approach. And our hope is that everyone is doing this form of care.
And
So
if I can,
yeah.
oh, I'm sorry.
No, please.
I just want to add to your answer. Hi, I'm Dr. Besbris. I've really just been enjoying watching Emily's awesome presentation and watching all your reactions to it. Angela, to try to be more specific, for example, if you were referred to see us after hospitalization, you may come into our office, or we might see you just like this on Zoom. We're going to ask you how you're physically feeling. So we're going to ask you what symptoms have come up in the hospital or during the transition home. Are there things on your day-to-day that are making it physically harder to engage with your quality of life as you transition back home from the hospital in your example, or in general? So is there pain or constipation or insomnia or anxiety? Is there shortness of breath or drooling? What's making it hard? What's interfering in your ability to enjoy today and tomorrow? We're going to talk about how you're emotionally processing your illness and what you've been through. And ideally in palliative care, we're working with chaplains and social workers. We're going to ask your care partner, whoever's caring for you, how they're holding up through all of the ups and downs. And in your example, Angela, of just coming home from the hospital, I also want to get into your goals and values. And this is a great opportunity to say, what was it like being in the hospital, right? What was your experience? If you were to get sick again, do you want to go back to the hospital? And if so, what's most important to you when you're in the hospital that your doctors need to be honoring? And if you don't want to go back to the hospital, well, what does that look like? So all of that is what would happen during a palliative care visit, as opposed to sort of the narrower scope of hospice, which is someone who's already identified that they're at the end of life. And how do we make that a comfortable time? So your example, Angela, of being someone with many years to live, that's most of our patients in palliative care, are people way ahead of end of life. And our job is to try to find ways to chip away at anything that's making that life harder, to try to help people and their partners feel better.
Sounds wonderful. So glad that this has developed. We have some questions. Someone says, June says that her palliative care only works by telephone. Do you think she can just find a different palliative provider? Does that sound unusual to you?
I don't know where June lives. I think it really depends on access. I think that, for example, in Los Angeles, there are actually 3 centers, St. John's, Cedars-Sinai, and UCLA, who all provide in-clinic and telehealth. And Los Angeles actually has many organizations that do provide home-based palliative care that do home visits. We don't, but there are organizations that do. If June is living, however, in a more rural or remote area, or just a different state that has less access to palliative care, it's possible that that's being provided by video visit or even telephone. So it's not necessarily unusual depending on where you live, but it would be very unusual here in Los Angeles. There are lots of ways other than telephone that we here provide palliative care.
And then for the second part of June's question, I'm going to recommend that she attend our support groups and ask for recommendations for movement disorder specialists. It's an interesting question. Are both patients and care partners capable of seeing a neuropsychiatrist for the different challenges they face? So they said neuropsychiatrist. And how would you be different than a neuropsychiatrist? When would you want to have a neuropsychiatrist rather than a palliative care nurse or doctor?
So when symptoms require medications or have been difficult to control, certainly we would make referrals to neuropsychs if we would just wanted to explore more about whether or not this was cognitive or behavioral. Traditionally, we're not involved in referring the care partners. We might be able to make recommendations, but usually they will follow up. I mean, we can make recommendations certainly, but
I think that a neuropsychiatrist is really focused on cognitive evaluations, as well as sort of digging into the mental health concerns that can come along with an illness. And so we do refer to neuropsychiatrists, certainly, to help people if we feel like we need a really detailed cognitive assessment, or sometimes for the purpose of therapy or medication management of severe mood disorders, severe depression, severe anxiety. Emily and I are often mistaken for therapists because we do tap into that psychosocial and emotional piece. We do ask people how they're doing. We do reflect about the illness journey, and we do try to parse apart existential distress of living with a serious illness. So we often get mistaken for psychiatrists or therapists. That's not our training. And so we are, I think, pretty good at sitting with people and helping them work through some of the emotional difficulty that does come up in dealing with illnesses like Parkinson's disease. And we refer out when we recognize that someone's needs go beyond what we can provide. If someone needs therapy, we know that we're not therapists, and we'll refer out. Same thing with neuropsychiatry.
Great. So a neuropsychiatrist is somebody who would see somebody like with Parkinson's or Alzheimer, somebody who had a neurological disease and needed medication for either emotional or symptomatic traits. Is that right?
I think, so I don't know a lot of neuropsychiatrists. I know a lot of neuropsychologists. And so they may engage in therapy or, and they may do cognitive assessments. A psychiatrist is someone we might refer to for very intensive management of refractory mood disorders like depression or anxiety. But neuropalliative care, again, is more of a whole person, whole disease, overarching approach to quality of life, which sometimes doesn't involve dealing with the emotional challenges of illness. A neuropsychiatrist is not necessarily trained in everything that we're trained in. A neuropsychiatrist can't help you with your constipation. They can't help you with your sialorrhea. They can't help you with maybe the day-to-day of living with Parkinson's disease in the same way that perhaps Emily and I can, in the same way that we can't necessarily progress you through really intensive treatment of mental health concerns that are related or unrelated to your Parkinson's disease. I really can't speak to what neuropsychiatrists do. I can only speak to what we do.
So from what you know, would a care partner see a neuropsychiatrist, or would they just see a regular psychiatrist?
Typically, they would see their own psychiatrist, because a neuropsychiatrist is specially trained to see someone with a neurological condition.
Makes sense. Just a quick question. Somebody asked, does Kaiser support this? And I know that I go to the Woodland Hills Kaiser, and I have seen a palliative look like a department. So I don't know how much you guys know.
Yeah, and someone mentioned USC too. So there are palliative care programs at a lot of different institutions. Little difference, but I think significant between that and what Emily and Dr. Hawkins and I do here, or what Dr. Siegel does at UCLA, or what Dr. Akanksha Sharma does at St. John's, is that we are trained in both neurology and palliative care. So there are lots of great palliative care specialists who can help. And if you're not living in an area with neuropalliative care, I think some like Kaiser, I'm sure, does wonderful palliative care. We are trained in neurology as well. And so we also understand the physiology and complexity of Parkinson's disease and other neurologic illnesses and how that interfaces with palliative care.
I'm curious from both of your perspectives, the difference between in-person and telehealth for you as physicians. Do you feel is one better than another? Does it depend on who you're seeing? And how do you handle that?
Yeah, oftentimes it's a challenge for people to come into the clinic. So I feel so honored that we're able to do these virtual visits on video. And certainly those that can come in, it's very beneficial to be able to see them and evaluate their ambulation. It's a richer experience when they're in the clinic, certainly. But yeah, no, they're both important. I mean, whatever access we can provide so that they're not missed, so that symptoms don't go, that go unmanaged, and we can prevent significant events from happening.
Great.
Yeah, I'll say it's wonderful to see people in person. I love to be able to do an exam. I love to see people face to face. I think that connection matters. And as Emily said, many of our patients, especially with more advanced stages of illness, cannot come to the office, and that shouldn't mean they can't access our care. And I actually love being able to see where people live too, to see what it's like to navigate your home, not only from a safety and sort of practical perspective, but how do you live and what's the art on the walls and, who's around you and who are your pets? I mean, I love doing telehealth because it gives me a sense of what your day-to-day life is like. And it helps me find even more opportunities to help you stay healthy enough and feel well enough to engage in that day-to-day life. So we do about, I would say 70 to 80% telehealth, just because of the fact that many of our patients can't come in, or it's really hard for them to come in. And I still think we find really wonderful ways to foster that human connection. I love being able to do telehealth.
Cool. Priya shared that she has an in-home palliative care nurse who comes to visit her mother in a community not in California, and it's covered by Medicare Part B as outpatient services. So that if it's Medicare Part B, it shouldn't matter which state. Any state should have that, something that it covers. Does that sound correct?
I think Medicare, yeah, should cover a state across the states in terms of
Right, because it's not like by state, it's a federal program.
right.
So that's good to know. That's encouraging.
There's been more and more home-based palliative care programs popping up. And I think that, and some of them I think do get covered by particular insurances, whether private or federal, and some of them don't. I think that if it's being offered to you and if there's no significant cost to you, it's a wonderful addition. I will say that there are some palliative care programs that are designed to continue for years and to take care of you. And there are some home-based palliative programs that are more designed as a bridge to hospice. And it's important to ask that question when you start, because you may not be anywhere near readiness for hospice, and you don't have to be. No one should be rushing you. And so if you're going to sign up for a program that you're hoping is going to be with you for many years, you just want to make sure that that coverage is going to continue for as long as you want and need it. That's different from clinic-based palliative care. We have no incentive or desire to transition people to hospice any sooner than they're ready. But I would check with your home palliative care nurse to make sure that that program is a longitudinal one and not designed as a transition time. I'm trying to answer some things in the chat too.
I know, I was wondering, is it okay for us to respond? I really wanted to acknowledge Charles' question about hospice, the expectation that people have to die within 6 months. Yes. Oftentimes people go on hospice and they end up doing better. They end up improving, and they can actually live for years on hospice because of the exceptional care that they can get at home. So people don't have to die. It's when could we foresee something happen that might end their life sooner in 6 months. I hope I answered the question.
I'm noticing 2 questions about medical aid in dying, which is, again, a small piece of what we do. And some of you are joining from other states, but in California, medical aid in dying is legal, meaning that people can ask for doctors to prescribe medications that allow them to end their life on their own terms. The law in, I think, every state where it's legal does require that you be in the last 6 months of your life, meaning we can't prescribe life-ending medications to people who objectively appear to have many, many years to live. And we want to then sort of dig into, well, what is making you ask for this and how can we help your life have a better quality? But for people who are expected to have less than 6 months to live and live in a state where the option is legal, it is something that we do field requests for and that we can't help with in palliative care. Kathleen asked about people at the VA, and that's an important question. And unfortunately, medical aid in dying is not legal federally. It's not legal nationally. And so you're right, unfortunately, medical aid in dying is not an option for patients who are receiving care only through the VA. If patients also have Medicare and are seeing a non-VA provider, that should be okay. But unfortunately, the VA, as I understand it, and I don't work at the VA now, but I did, as I understand it, the VA is not able to support medical aid in dying requests because it is not legal federally. And I may have my own personal feelings about that, but I realize this is not necessarily the forum to air those personal feelings. Barbara asked how we address requests for medical aid in dying when the patient wants it and the family doesn't. And I think this is a broader question too. We don't only see conflict in requests for aid in dying. We see conflict sometimes within families or between patients and families about certain medical choices like feeding tubes or hospitalization or the timing of initiation of hospice. And this is actually, I think, the thing that we as palliative or neuropalliative care specialists are trained to do the best, which is to ask people where they're coming from and try to bridge those gaps. So if someone came to me asking about medical aid in dying or hospice or asking about feeding tubes, and not everyone in the family is on the same page, I'm first asking that person, that patient, why they're asking me about this, how they've reached the choice they've reached, what they're thinking about, and asking the family what their feelings are and what's holding them back or what's concerning them. I think when we have a really good conversation, most of the time we can resolve that difference. If a patient has the cognitive ability to make their own decisions, we're going to honor those decisions. But that doesn't mean we don't want to understand where there may be conflict and try to help bridge that gap. Because I do think that we're here to take care of everybody, right, in the family unit, and recognizing these choices affect everyone. And so we do want to try to help everyone understand where each other is coming from and get on the same page as much as absolutely possible. Emily, I wonder if there's anything you wanted to add to that or any other questions that you saw in the chat that you wanted to address.
I noticed that Larry has a lot of complicated illnesses, and I wondered whether, in his case, you want to make sure you had an MD rather than a nurse practitioner, just because it's so complicated. That was my only thought that came to my mind.
And I want Emily to answer that, but I'm going to answer first because as a doctor, I want you to hear me say that the entire interdisciplinary team is important, and even more important if your illness is more complicated, meaning I think that in general, you should always have the whole team. You should have a doctor, but Emily as a nurse practitioner thinks of things that I don't, and vice versa. Social workers similarly is going to see opportunities that we don't. Same thing for a nurse, same thing for a chaplain or a pharmacist. So I think that team approach actually becomes more important the more complicated your illnesses are. And Larry, I'm so sorry that you're dealing with so many different problems at once. And I think that would make it even more important to have a palliative care team, to have that whole person approach. And even more important that that is not just a doctor. Because I'm looking and I'm thinking already as a doctor, oh my gosh, Larry should have access to an amazing nurse practitioner like Emily, who really understands how to look at the whole situation and think about, well, what are you at risk for and how can we prevent it? And a social worker to help you work through the different challenges you're facing and how do each one of those affect your personhood differently and your needs differently and so on and so forth. So I think that, yes, as a palliative care doctor, I hope we have a role, but I don't think there's ever a time where I think you should only or exceptionally have a doctor. I actually think the team becomes more and more important the more complexity there is in your care. Emily, what else would you say to someone like Larry who just has so much going on?
Yeah, I would say that the needs would drive this approach and coming to a palliative care team, and that, yes, that we really are like a we team, that the benefits of having different perspectives to help improve and prevent complications is really vital. So yeah, and any questions, and we definitely, there are things, we definitely know we don't know things, and I think that's important. And we work together to find a solution.
I hadn't even
That
thought of
answers the question.
social workers being part of your team. That's interesting.
They're a huge part of our team. And I want to acknowledge that there are social workers who deal with practical matters, right? Like when you're leaving the hospital, planning care at home, or hiring caregivers. But palliative care social workers actually have special training in, frankly, therapy. And so they're not just there. They are there for the practical complexities of your day-to-day, but they're actually really specifically there to help you face the things that are emotionally really challenging and to help care partners face the parts of illness that really grind at you. Are you feeling isolated because it's hard for you to communicate? What is that like? How can we help you work through that? Are you feeling anxious about going out for dinner because you're afraid of coughing or choking on food? And how is that affecting your isolation and your willingness to engage in activities that you used to enjoy? So social workers actually have a really special type of expertise that those of us with the more medical, MD or NP sort of side of things don't have. They're an indispensable part of a palliative care team.
Also, Thomas Meyer has a father who has advanced cognitive symptoms. And to me, reading that, to me, that looks like a palliative care would be, that this would be a good time for palliative care.
Yeah, so we could have like the whole person approach to see what medications dad's on, just to explore more about the tremor. And it's really important is to tell your providers what is we don't want providers assuming what is causing the most stress. And I think it's really important, Thomas, that understanding that dad is really upset about the tremor, we could explore more. What else might be upsetting dad? Is it really the tremor? With a cognitive impairment, or is it something else? Is it pain? Is his inability to bring nutrition or get a drink or grab the remote control or whatever it is? There's so many things to explore, because we know when individuals have any kind of memory impairment, there may be needs he's not able to express. So we don't want to assume. But I really appreciate your advocating for dad and trying to help improve his distress.
I agree with all of that. And I would also say, if dad's tremors are most bothersome when he's at rest, which we know is typical of a Parkinson's tremor, we know sometimes they can have an action component as well, but we know that, the most common type of tremor, as you pointed out, is this resting tremor. While medications can be helpful, there are other behavioral strategies that we can use. I would suggest that if dad's tremor actually gets better with movement, that distraction and giving him more to do with his hands might actually be really helpful. And so, for example, if there's something that he likes to do, if it's the feeling of clay, if dad is an animal person, they actually make, and especially with cognitive impairment, there are these, I don't know the exact name for them, these kind of animatronic pets, like cats and dogs that are stuffed animals, but they purr and they move a little bit, they respond to your touch. Or if dad is someone who maybe had a profession where he was doing something with his hands, folding laundry, folding pieces of paper, giving someone something they can do with their hands is both distracting and also gives their hands something to do so that they're not dealing with tremor because their hands are in movement and not at rest. So I think that can be a helpful distraction, since, to your point, with advanced cognitive impairment, dad's not going to understand when you're telling him verbally and redirecting him, oh, dad, that's just your tremor, it's your Parkinson's. So distracting his hands and his brain from that tremor might be a more successful approach. And that may be the kind of thing that we would troubleshoot. I agree with Angela that this might be a really important time for having a palliative care team to help dad.
I'd like to add a little something as well. As a caregiver for 18 years, I do want to say my husband Sandy was on palliative care. Unfortunately, it wasn't quite as early. I wish we would have had it at the very beginning, but it wasn't recommended until a little bit later down the road. But I do want to say that I think for the care partners that palliative care can be such a lifesaver for you. Being able to navigate and understand the different aspects of getting through that care partnering, making appointments, just explaining the difference between the neuro social worker and, let's say, a hospital social worker, who really, their position is not to help you when you're discharged from a hospital. And so being able to have that opportunity to speak with someone directly and have access. I'm sure everyone on this call, regardless of the state that you are living in, has found it difficult oftentimes to get to your MDS or to your neurologist to get through. And the palliative care, I looked at it as a tree of just branching. It allowed me to reach further than I could reach by myself, to be able to maybe get to another specialist and see things that I could not see. And that's why I felt this was so important for us to present this for PCLA, because the value is immeasurable. So thank you. It's been great. I love everything you've said, and I hope that our viewers have gained a lot from it.
I'm sure they have. It's overwhelming how much there is to think about. I mean, it was beautifully laid out, but it's still a lot. You really need palliative care specialists to figure out what the heck to do. Um, is there
If,
anything, Judy, did you say
if there's any last minute questions that anyone has, we have a couple minutes more.
somebody would like to unmute themselves and ask a question? We have time for one more very quick question.
Do you have support groups for the caretakers through your agency?
So at Cedars-Sinai, we do have a caregiver support group. I know USC has a real robust caregiver support program. So yes, we do. The neurology clinic at Cedars, there are social workers that help to run caregiver supports. And then I know at USC, it's maybe more frequent, but they're out there for sure.
And they're online if you want, if you don't.
Yes, they are. They're virtual. Yes.
Thank you.
And to Judy's point, it's not our support group, right? It's not the neuropalliative team that's putting it together, but part of our job is to know about all these community resources so that we can help link you up with that support group or that respite care or whatever the case may be. So, I would just say that if this sounds like a type of care that would be really helpful, if you feel like there have been things that have been hard and you're looking for someone to shepherd you and your loved ones through this illness, I would encourage you to, ask your movement disorder specialist or your primary provider if this is something that they would refer you to reach out to us if you're wondering if it's something that we can provide for you if you're living in the Los Angeles area or in Southern California. But sometimes, referring providers, neurologists, and other specialists aren't thinking about palliative care, even though it's the right time. And so I would encourage you to really advocate for yourself and ask about this and see if this might be right for you.
On that beautiful note, I want to quote one of our chat people, MB Sorensen, wanted to thank you for this excellent informative presentation. I am so grateful for the care you have provided for my husband with his advanced neurodegenerative disease. You are both incredibly personable professionals and have helped us so much. So thank you so much for your generous time and incredible breadth of training that you shared with us. We are going to move on to our final thank yous. Thank you again to Emily and Dr. Besbris, and thank you all participants for joining us today. You had some great questions. And today's event was made possible by our sponsors, Abbott, Acadia, and Boston Scientific. We have some wonderful events coming up, which I'll tell you about in a moment, but if you enjoyed today's program, please visit PCLA.org and make your donation. Your contribution to PCLA is critical to our mission to improve the lives of families in our community living with Parkinson's. You can find our contact information on the bottom of this screen. And PCLA is a nonprofit. All donations are tax deductible. We are excited to invite you to our highly anticipated in-person event, the annual Let's Taco Parkinson's. Mark your calendar for Wednesday, October 23rd for an evening dedicated to both education and fundraising. We're thrilled to offer a fun social evening with delicious food, but also the opportunity to hear from two distinguished movement disorder specialists, Dr. Katie Cross and Dr. Daniel Thorstison. We can't wait to see you there. We're going to have a blast. Links to register for this event, as well as updates for all of our programs, will be sent out to our email list, or you can visit pcla.org. Thank you, everyone. Have a super day.